Hey, good morning, good afternoon, good evening, everyone. This is Paige Nuel, Director of Family Empowerment at RettSyndrome.org. Welcome to today's RettEd webcast. On behalf of our Board of Directors, our staff, our entire team, we're so pleased to bring you today's presentation on autonomic issues in Rett syndrome. It's one of the most challenging and perhaps more heartbreaking aspects of Rett syndrome, yet an exciting area of investigational research for Dr. Nuel. Your children are really important to us. We want to take this time in our RettEd presentations to get you more comfortable with the research that's happening in some of these symptomatic areas of Rett syndrome, but also give you an opportunity to learn more about what's going on with your children, to understand some of the things you're observing, and give you vocabulary to talk to your own practitioners. Also, at the end of this presentation, you'll have time to ask Dr. Nuel some questions in areas that maybe we didn't get to in the presentation. So we invite you to please visit RettSyndrome.org to make sure you're signed up to receive all of our communications on all kinds of topics: research, family empowerment, fundraising, advocacy, and awareness. And explore our website for further information regarding all of these different programs. We encourage you to be part of the change you want to see by participating in fundraising for RettSyndrome.org, as well as participating in current and open research studies such as the Natural History Study, the Sirizitan clinical drug trial targeting breathing issues in Rett syndrome. As we mentioned on last month's RettEd, I hope everyone is familiar now with the new enrollment age being 4 years old. If you are interested in that trial, please reach out to me. We're reaching the final enrollment and we just need a few more kids. So if that's a trial that you're interested in, please reach out to me. We also have many other clinical research opportunities and trials that will begin later in 2018 into 2019, and those are listed on our website. The RettEd webpage at rettsyndrome.org/RettEd is where you will also find our calendar of upcoming events in your community, as well as future webinars. A registration is open for all of the webcasts, and you can find links to prior RettEd webcasts and conference presentations on our website as well. So before we begin, I'd like to share some brief tech points on how GoToWebinar operates if this is your first time joining us. So the audio feed is open to our presenter only, so you don't have to worry about your background noise interfering with the presentation. If you look at the upper right corner of your screen, you'll see a control panel window, and we invite you to type any questions or comments in the question field throughout the presentation, and we'll answer these at the end of the slide presentation, as well as get to the questions that were pre-submitted at the time that you registered for the webinar. If we don't get to your questions today, we'll work with Dr. Nuel to get all writing questions answered and posted in a QA document on our webpage once that's completed. So if the control panel window is distracting you, you can minimize it or move the window, then expand it, and at any time if you wish to submit a question. The next point of great interest to everyone is that yes, this session is being recorded. We will post a link of the recording along with the QA document to the RettEd webpage so you can listen again and share it with others. If you're having trouble hearing, please check and turn up the volume on your phone or device. Okay, so now I'd like to introduce today's speaker. Dr. Jeffrey Nuel is director of the Vanderbilt Kennedy Center. The Vanderbilt Kennedy Center is a 50-year-old center devoted to improving lives of people with developmental disabilities. And Dr. Nuel's current efforts in Rett syndrome are organizing and leading a Vanderbilt comprehensive Rett program, which pulls together basic and translational scientists with clinical researchers and clinical care providers to both provide optimal care for people with Rett syndrome, as well as develop new approaches to therapies. We're very excited to hear of this new comprehensive program that Dr. Nuel is building at Vanderbilt University. Much of Dr. Nuel's time currently is spent trying to pull together the renewal application for the Rett syndrome natural history study, which we wish him much success with, and pull together the new study consortium, as well as helping shepherd clinical trials for Rett syndrome at Vanderbilt and evaluating read-through compounds within his lab. So, Dr. Nuel, you're a busy guy. We really appreciate you spending some time with us today.
Thank you, Paige.
If you are ready, I'm going to go ahead and turn the screen over to you so you can get started with your presentation.
Great.
And there we go. I see your slides. So if you'd like to go ahead and begin. Again, everyone, you're on mute. The recording has begun, and Dr. Nuel is going to share some really important information with us now.
Okay, great. Thanks, Paige. I have a variety of information, both clinical and some more basic translational stuff at the end. I'm going to try to be cognizant of the time so that we have plenty of time for questions. So if it gets to near the end is the more esoteric stuff. So we may end a little early. I may end before the end of my presentation to leave the time for the questions. So let's see. Okay, here we go. Okay, so this talk is about the autonomic system and dysfunction in Rett syndrome. And this is just a basic overview of the autonomic system. And what the autonomic nervous system is the nervous system that controls the things we don't really think about but are critical for life. So it really controls things like your blood flow to your organs. It controls how your liver is working, how your gut is working, how your kidneys are working, how everything is working together. But the things we don't really think about. And it's really divided into two parts. One is called the sympathetic, or the fight or flight system, and the parasympathetic. And these have opposing effects on these organs. So I think a good example, if you look to the left, it has the sympathetic and has in the middle of your screen showing that a connection to the heart. So the sympathetic, as it's called, is the fight or flight. So when you have activity in the sympathetic, it causes your heart rate to go faster. It essentially says, we've got to get out of here. We've got to do run away or fight this person or something coming, this bear trying to get us. And so that's, and it sets up your whole body to do that. The opposite is the parasympathetic. And again, if you look at how it connects with the heart, it says it slows the heartbeat. And then, so this is sort of the rest and restore part of the nervous system. And so it basically does a lot of the opposite of things that you'd see for the sympathetic system. And you see that we have connections through all these different organs. And we're going to talk a little bit about aspects of the heart. We're going to talk a little bit about things in the bladder. It obviously has a lot of effects on the gut. And then, although the breathing system is not directly considered part of the autonomic nervous system because of the way the connections are, I would lump it together as a general physiological process that we know is abnormal in Rett syndrome, and we'll talk about that. So what are some of the things that we know are abnormal in these autonomic and physiological systems in Rett syndrome? Well, one is breathing. I think a lot of people who have children with Rett syndrome will recognize that their children have various breathing abnormalities. There's also what's called vasomotor, which is controlling the blood flow to your skin. And we oftentimes recognize this with cold feet. There's pseudomotor, which is sweating, which is something a lot of people have noticed with people with Rett syndrome have abnormal sweating. There's control of your bladder, there's control of your heart. Importantly, I don't have up here, but there's the control of your gastrointestinal system. That has a whole nervous system unto itself called the enteric nervous system that is regulated sort of above it by the autonomic nervous system. And I think we all recognize there's a lot of GI dysfunction in Rett syndrome, but I'm not really going to spend much time on that because really that's a topic unto itself. So one of the things that I mentioned was these breathing irregularities. And again, I think a lot of people on the call or who might be listening are familiar, but the breathing abnormalities are fast breathing, or what we call hyperventilation, or breath holding, or apneas. And oftentimes these might happen in conjunction, but they may happen independently. I think we've all recognized that they primarily occur when people are awake, although from more careful studies done in the mid-2000s, it does seem that there are breathing abnormalities, but not as dramatic when children are asleep, or at least at night. Here's a video. We'll see if it plays. Okay, it's playing on my screen. I don't know how well it's playing on yours, but you see she's having a pattern where she's breathing really hard and deep, and then she holds her breath, and lifts her heads up and then expels very hard. And so that's an example of this sort of repetitive fast breathing with the breath holding. I don't know if you all can appreciate the shirt. It's one of my favorites. It says, "I have Rett syndrome, what's your problem?" What you see below is an example of a tracing of a breathing pattern. And this is actually from the mice. This is what's called a plethysmography. So we put mice in a chamber and can record their breathing. And this is the breathing in and out of a normal mouse, a typically developing wild type mouse that has a pretty regular pattern of breathing in and out and in and out and in and out. And you see it's pretty regular. Now here's a mouse that doesn't have any MECP2, so we consider it's like a mutant mouse that might represent like Rett syndrome. And you see that rather than having a normal pattern of breathing, they have these periods where it's slower, and then it gets faster, then it pauses and stops, and then it starts getting faster. And so you see it's kind of irregular. So the animal models reproduce it. And these types of tracing are not dissimilar from what we might see with a person with Rett syndrome if we were recording their breathing using devices that are being used in various clinical trials. Now, we recently, through the natural history study, which I think a lot of people are familiar, that's been going on for about 15 years, we published this paper this year describing what has been reported, what we found reported in the natural history study for breathing abnormalities for people with Rett syndrome. And this is a pretty large group of people, ultimately about over 900 people with typical or classic Rett, and then people with atypical and some people who have MECP2 mutations who don't have Rett. And what we see here on the top is these are groups of individuals grouped into 10 groups by age, and you can see along the bottom the different age groups, going below 4 at the left end to above 25 years old on the right end. And what we have by the different color coding is how frequent breathing abnormalities were observed in those age groups, with the blue being meant that there's no breathing abnormalities. And then the other colors all represent some degree of breathing abnormalities, either by history in the green or observed in the clinic. And what you can see is by this cross-sectional, we'd call this, because we're taking everybody and just grouping, saying this is the age in the report, you see that sort of we have a peak amount of frequency of breathing sort of in these school years with the highest level of things that were hyperventilation, or especially hyperventilation in the 4 to 11 years with decline. But you still have presence of this really well into the 20s and 25. It's somewhat similar with the breath holding. It's a little bit more flat, where it doesn't have quite the dramatic up and down characteristic. But you see that actually a very large, especially breath holding compared to hyperventilation, a very large percentage of people at any given time are reporting that there is some degree of breathing abnormalities with, sort of in the 70-ish range, 60 to 70-ish range for most of the people observed, and even in the 60 to 90% or 80% range of people either observed or reported. So these are very common issues in Rett syndrome. And this is a different way of viewing this, basically the same data, because instead of grouping it into bins, we've just looked at what's called a cumulative distribution plot, which shows the proportion of people who have either hyperventilation on the left or breath holding on the right. And the blue line that's going up is showing the people who have typical or classic Rett syndrome. And as you can see, over time, the proportion or percentage of people who have hyperventilation climbs up to the point that ultimately is essentially approaching 95%, nearly 100% of people sometime during their life will have it. And you can see by 20 years old, it's almost 90% of people have had breathing abnormalities sometimes in their life, of hyperventilation. And it's basically the same with the breath holding. It actually it goes a little bit higher a little sooner, where you have 90% of the people probably by about 12 years old will show breathing problems. The blue line, like I mentioned, is for typical Rett. When we look at atypical or variant forms of Rett, and we divide it into either mild forms or severe forms. The mild is the green, and the severe forms is the severe atypical is the orange. You see that For the severe forms, the percentage of people who have hyperventilation and breath holding is basically the same as people who have typical Rett. But for the milder forms, it actually is lower, where you're actually only getting a peak level of less than 70% for hyperventilation and about 85% for breath holding. Now, we did have people who had MECP2 mutations who did not meet the criteria for Rett syndrome, and you can see a far lower percentage of hyperventilation or breath holding. Now, I'm going to walk through this a little bit because it's an unusual way to look at the data, but I think it's very interesting. And so in the people who were in the study, some of the people were seen once, or they were seen for a year, and some people were seen up to basically 8.5 years. So we have this plotted on the y-axis as the number of years the person has been in the study. And what each one of these little lines going up is a person. So you see that this person here on the far left, they were seen for about a year. And then if you look at in the green bar here, this person was seen for about 7.5 years. Now, what this is showing is it's color coded by over here on the left are the people who had never had any history of breathing problems, or they had them, but they don't have them now. So you see there's a small percentage of people who don't have any history of breathing problems, or they had it in the past, but they didn't have it at all during the study. Now, on the opposite would be over here, this very large group of people in red, which represents people who had breathing problems at the start of the study that they were seeing, and they had it throughout the entire time that they were observed, either from 1 year on the left all the way up to over 8 years. And you see, actually, that's the largest group of people who had continuous breathing dysfunction throughout the study. Finally, in the middle, we have people that had breathing problems, either had breathing problems at the time of the study or did not have it, but started having it. So this is sort of what we're terming a relapsing remitting, where people have it, but it might go away for a while, and then it might come back. And you see the pattern is a little bit variable in terms of when it might be starting and when it might be stopping. But those are the second largest group. This is really the same information presented just in a little bit different way, and it's a little bit more complicated, but what we see here is this now on the x-axis along the bottom is the age in years, rather the age of duration in the study, but the age for the person during the study. And again, this is each one of these now horizontal lines represents a person, and we have color coding that indicates what their breathing dysfunction is. And one of the things I'll apologize for you is that the color coding is not necessarily consistent between these two graphs. And so the important thing is if you look down here at the very bottom, which is this dark blue, these are people who never had any breathing dysfunction anytime during the time that they were in the study. And that was about 3% of the people. Now, up here at the top arc are people who had breathing problems during the study, and they had the breathing problems consistently throughout the study. Now, it may change in how severe the breathing was, but it was present essentially throughout the entire time that they were in the study. And that was basically 60% of the people had breathing problems the entire time they were observed. And finally, in that middle group, these are people what we call the relapsing remitting. So the top group would be the consistently having breathing problems. The very bottom is the people who never had it. And in the middle are the relapsing remittings, where they had patterns where they either didn't have any breathing problems and then started, or they had breathing problems and then it went away. And you see that's about 37% of people. And about 20% of people during the course of their observation went to the point where they either stopped having breathing problems for a while, or they stopped and it stayed away. Okay, and then just to talk a little bit about some of the other characteristics and how it compares, is that some of the people, this is relation of breathing problems to other problems in Rett syndrome. And you see a variety of things here on the left of poor hand function or severe difficulty walking or frequency of repetitive hand movements. And essentially all of these things were correlated, they were significantly related to having breathing dysfunction. So what that means is people who had poor hand function oftentimes had severe breathing dysfunction. And all of those things were correlated. And one of the things that's important to recognize is things like the overall dysautonomia, which is abnormalities in the feet, the cold feet. That was very, very significantly related to the hyperventilation or breath holding. And so indicating that there may be a consistent set of problems that are leading to both. We also saw, and I haven't gotten to this yet, but the abnormalities in the heart rhythm was also correlated. Interestingly, there was overall relationship between higher weight and higher body mass index, which is associated with less breathing abnormalities. And this sort of goes along with a lot of general things we've observed, which is people who are oftentimes people who are less severely affected in many of the domains in Rett syndrome have higher weights and higher body mass indexes. Oftentimes these people have more issues around behavior than people who have more severely affected who are also lower weight. So this fits with other things we've observed in the past. So that's sort of a summary of this recent paper, and I thought it was important to discuss because it sort of represents the kind of work that we really has cumulative come out of this natural history study and how important this natural history study has been for us to understand the clinical features in Rett syndrome. Now, thinking about how we might approach treatment, and this has been a challenging feature. I think we've recognized that there is some degree of anxiety overlay. I think a lot of families have told me that, you know, they'll notice that it's more prominent when they're in a loud, noisy place, or they're in a new place like in the mall, or when they come to see me as the doctor. And so we know that there's some amount of anxiety, and so we start thinking about what are possible ways to treat it. And one of the approaches that we've tried is things modulating neurotransmitters called serotonin, which are that's a neurotransmitter that's very important in anxiety, but it also is very important in the brain regions that control breathing. So we've done things like try Buspar and serotonin reuptake inhibitors that are usually antidepressants like Prozac or related drugs. And I think that clinically that has been these have been my go-to drugs. It's variable. Some people seem to have some success, some people don't. We don't have any controlled trials of this, so we're really kind of going by our clinical anecdotes. Now, it was mentioned there is an ongoing clinical trial for Cerazozan or Cerazozan by a company called Neuron. And this has evidence from animal models of improving breathing. It has a similar property to the Buspar, but it actually is it's a stronger drug in that domain than Buspar is. So it'll be interesting to see how that clinical trial plays out, because that might provide a new avenue for therapies if it's successful. Some of the other ways that we've approached treating these breathing problems is modulating a neurotransmitter called GABA, using drugs like benzodiazepines. And a classic example of that is Valium or Klonopin. Again, I found variable success with that, but it is something I would consider. There's been a lot of interest in the role of carbon dioxide. There are some drugs, some that are diuretics or things that get rid of liquids called like acetazolamide, which change the way your body handles carbon dioxide. It actually changes the way your body handles hydrogen, which carbon dioxide then gets related to. Other drugs like Topamax and Zonegran, which are anti-seizure drugs, also have this effect. And we sometimes will find that these drugs may be beneficial. Again, these are uncontrolled anecdotal experiences, and I can't say that these have been highly affected and definitely not in everyone. So it's kind of a trial and error approach currently. Now, there has been a report from quite a long time ago about use of ketogenic diet in Rett syndrome and the secondary effect of improving breathing. Now, ketogenic diet also changes some of the acid-base aspects that like the carbon dioxide might be affected, and so it could be secondary to that. Finally, there was a trial in the early 90s using an anti-opioid drug called naltrexone. And again, there seemed to be some improvement in breathing. This is not a drug that is commonly used. It's not a drug I would commonly use, only because we really don't know how effective it could be, and it has potential liver toxicity. So I have used it, but it requires pretty close monitoring of liver enzymes. So it's sort of something that I would approach only in the most severe cases when all the other options have really failed. Okay, I'm going to switch gears a little bit past the breathing, and I know I spent a lot of time on that, but I think it's important things to cover. And I'm going to talk a little bit about the other aspects, this vasomotor, pseudomotor. So like I said, the vasomotor is represented by these cold hands and feet, and I'll play a video while I'm talking of me pressing on a child's foot, and you can see how it blanches because it's kind of purplish. If you felt it, it would be cold. And this can be from, oftentimes going towards the blue. Now, we usually think of it being cold and blue. However, it can be hot and red at times. And so here's a picture of a hand of a young woman I saw during a natural history study visit. And her hand, you can see, is red in the fingertips. And there's a boundary here in the middle of her top of her hand. And this was coming and going, and it would be very hot. So these are, again, are vasomotor. Sometimes it can be cold and blue. Sometimes it can be hot and red. And sometimes you can see that in the face with the face flushing. Now, in terms of what we call the pseudomotor, that's this abnormal sweating. And I think we've noticed that girls with people with Rett syndrome oftentimes have unusual sweating. They don't necessarily sweat well when they should, which is to regulate their temperature, but instead seem to have like a nervous sweating where they're sweating in the palms of their hands and the soles of their feet. So it's not really doing what you're supposed to do. It's not coordinated correctly. Now, there's been interesting anecdotes, and this is another person I saw from the natural history study where this person had during a scoliosis surgery, accidentally the surgeon cut what's called the sympathetic ganglion. These are the nerve roots coming out of the spine that have all the sympathetic part of the autonomic nervous system. And these are the ones going down to the foot. Now, when this happened, it was an accident during a scoliosis surgery, and it cut the left side, going to her left foot. So if you see here in this picture, her right foot is purple, and if you felt it, it's very cold. But her left foot is normal color and is warm. Besides that, you see that her right foot is swollen, and we would call that a neurogenic edema. So we would not recommend this as an approach to therapy, but it does potentially give us an idea that these abnormal vasomotor symptoms are probably because of an overactive sympathetic nervous system to the periphery. And the folks up in Minnesota, led by Frank Simons, have done some interesting work that was published a couple of years ago using infrared thermal cameras and looking at the asymmetry and looking at the temperature difference in the feet. And here you see a picture of a foot. On the right side, you can see it because it was hot, and the left side was cold, so you really didn't see it. And they showed that there were a lot of asymmetries, and that this might be a way for us to quantify these abnormalities in the temperature of the feet, the extremities, and that could be something that might be interesting during the course of a clinical trial. So again, the treatment, well, the vasomotor, these cold blue feet or warm red feet, we don't really have any particular treatment for this at all. I think that most families will oftentimes keep their children's feet in heavily swaddled in socks and other things to try to keep them warm. In terms of the sweating, I think this is an important thing about being careful when your child or adult with Rett syndrome is in hot places, because they're at risk of getting overheated and potentially getting heat exhaustion or heat stroke. So I usually tell families that if you're sweating, you should check to see if your child is sweating. And if they're not, you really need to cool them down. Spray them with water, get them in the shade, get them into somewhere cool. Now, there are a variety of drugs that can exacerbate this, such as those drugs I mentioned for the breathing, like Topamax or Zonegran or acetazolamide. So it's even more important to check this if they're on any of those types of drugs. Okay, I'd like to spend a little bit of time now talking about bladder dysfunction, which is something that I think that we've only really started recognizing as an issue in Rett syndrome in the last 5 years or so. And we published this paper a couple of years ago trying to describe this both from things from the natural history study and from animal models. And what we noticed is in the natural history study that there was a significant number of people who had some degree of urologic, so the urinary tract system dysfunction. And these are all a bunch of different types of abnormalities. We saw a fair amount of people with urinary tract infections, with kidney stones. We saw people who ended up having to have surgical. They were having to have recurrent straight catheterizations because they were having urinary retention, and ultimately having to have surgery to have a stoma or a tract put in to do the catheterization other than through the urethra. And so this was interesting that we are seeing more of this in the natural history study. So we looked at mice, and we looked at the Rett mice to see how they produced urine and what their urine looked like. And so what we have here is in the blue, or on the left side is always boy mice, and on the right side is female heterozygous mice, which is really the disease model for Rett syndrome. And what you see is that in the mutant mice, we saw more numbers of spots, which is in blue, than the wild type mice. But the total amount of urine was the same because they were making very small spots. So they were doing a lot of little spots rather than just larger spots. So it was like they couldn't get the urine out as well. And then when we looked at mice when they were healthy, all of their blood chemistries, when we look at things like the salt, like the sodium and the potassium and a variety of other blood chemistries, when they were healthy, they were all pretty much normal, like the wild type. But when they became sick, they started having signs of kidney failure, where they weren't getting rid of potassium as well, and they were losing things like this is called bicarbonate, and they were retaining things that are products of muscle breakdown, like blood, urea, and nitrogen, which indicates that they were in kidney failure. And we saw that in these mice, they were having an obstruction. These were male mice. They were having obstructions in their urethra. That's what this is. This should be a tube going through, and there was a blockage, which is shown here on the right. This is a blockage. And furthermore, their kidneys, which are shown here in D and D prime, are swollen. So you see the normal kidney, it looks like a little kidney bean, but the mutant animal has big, and it's pale colored, and it's swollen. And this is just a section through that showing how swollen it is, like the urine is not getting out. And so this is just showing that we saw that this seemed to have a different effect depending on the background strain of the mice, of how much they would have these bladder, distended bladders, and how it related to these animals dying, indicating that there may be other genetic factors that influence this. So I think the important message here is that it's important to keep track of the urinary output. And so I usually counsel families and clinicians that it's important to understand how long your child goes without a wet diaper or urination. Are they potentially holding in the urine for long periods of time? And then do they suddenly have like a big outflow, or is it kind of dripping out over time? And of course, you have to always be careful if there's a strange color or it's a foul smell, because that could indicate that there's a urinary tract infection. Now, if your child is having abnormal urinary output, like because they're retaining urine, they may need to see urology. And urology, the doctors who care for the bladder, can do formal tests to test how the function is. In some cases, if people are retaining this urine in their bladder a long time, that's a big setup to have a urinary tract infections, so you might have to do catheterizations to get the urine out. And in the severe cases, you might have to have surgery to create a new hole to allow for this catheterization to occur easier. There are a large number of drugs that can worsen this. One of the most commonly that might be used is called Robenol, which is used to reduce drooling. And this can also reduce the amount of how well the bladder works and it might retain. So it's just something I caution about. Okay, finally, I'm going to spend a little bit of time talking about cardiac abnormalities. Now, we've known for many years that there is sudden death in Rett syndrome. In the natural history study, we've observed at least 20% of the deaths were sudden and unexpected, and we don't really know the cause. And there's a variety of things that could be causing sudden unexpected death, such as breathing abnormalities or seizures, but we're concerned about these cardiac rhythm abnormalities. And the cardiac rhythm abnormality in specific that we're worried about is what's called QTC prolongation. So if you see here on the left side, this is trying to diagram what an electrocardiogram is measuring. These are electrical waves. And what they're representing is the electrical activity that is flowing from the top of the heart through what's called the atrium, which is shown here in red, is this red wave called the P wave. And then as that electrical activity, and that's caused the contraction of the top of the heart, and then as that electrical activity flows through the rest of the heart, which is called the ventricle, it causes the QRS in blue here. That's the electrical activity, and that's the heart pumping. But then the electrical activity has to reset or repolarize, which is the T wave. And so the time from the beginning of the Q wave to the end of the T wave is that complete electrical cycle where it depolarizes and repolarizes, and it's essentially an entire cardiac cycle. Now, we found that people with, there's at least 20%, well, almost 18%, we're seeing this a little higher now as we look, of people in 2011 from the natural history study had a prolongation of the QTC interval, people with Rett syndrome. And that's shown this dotted line on the right. And the people above that dotted line, we say had a prolongation of the QTC interval. Now, why do we care about this QTC prolongation? That itself is not something anybody would feel. But what we know is that there are people who have isolated forms of a long QT syndrome. So these are genetic reasons to have this. These people don't have other problems, but they have this QTC abnormality. And we know that that increases the susceptibility to develop what's called ventricular tachycardia. And down here, we see a normal rhythm. And ventricular tachycardia, you see the heart's beating really fast. When it beats fast like that, it doesn't pump the blood efficiently. And so the blood doesn't go to your brain, so you pass out. That's called syncope. And it can cause death. So we know that this increases the risk of sudden death. And so that's the reason we are concerned about long QTC and why we think it might be underlying the sudden death. And then so I think I'm not going to spend a lot of time on this because this is getting into this more science, and we're at 39 minutes. I'll just kind of cover it a bit, the work that we've done to use the mouse models to characterize this. Essentially, we found that the mice do have this. They have a QTC prolongation, which is shown in the bottom left here. And we showed that these mice are susceptible to developing cardiac arrhythmias. So we pass a catheter down into the mouse's heart, and we can record and stimulate the heart. And when we do a particular stimulation pattern and then stop, you see the wild type mice go back to a normal pattern here on the left. But the mutant mice, a significant fraction, develop this abnormal ventricular tachycardia. Now we found that was if we induced the stimulation of this, but we found that if we recorded the mouse's heartbeat for hours and hours, we could find abnormal heart rhythms. In fact, what we found was the wild type mice had this normal pattern, but the mutant mice had a slower heart rate and had abnormal periods where the heart rate was going really slow and was big pauses in the heart rate. And as we looked at it more carefully, we saw specific abnormalities in terms of having particular slowing periods called a sinus pause or an AV block, or even sometimes premature ventricular tachycardia or a non-sustained ventricular tachycardia. And so we found these spontaneous cardiac abnormalities in these mice. I'm not going to talk about that. That's about treating with various things. But in some of these cases, these mice, as we were recording them, because we were recording them for multiple days, happened to die while we were recording them. And when we looked back in the hours before and the days before they died, we found that their heart rate was declining. We found that their temperature was declining and their activity was declining. And what we found was their heart rate was slowing and having more and more of these abnormal rhythms to the point that it just stopped. And so we used a variety of genetic tricks to figure out where the MECP2 or the gene that's involved in Rett syndrome is required. And the summary of this is that we found that it wasn't that it was a problem in the heart, but we found that it was the problem you needed to have the MECP2 in the nervous system. And specifically, as we went further into the parts of the autonomic nervous system, the sympathetic versus the parasympathetic that I mentioned to you before, we looked at the parasympathetic nervous system. And again, I'm skipping the actual data here, but we found that it was really when the MECP2 wasn't in that parasympathetic system that we had these cardiac problems. And this is suggesting that maybe if we had ways to manipulate it looked like the parasympathetic system going to the heart was abnormally high, causing this slow heart rate and potentially leading to having these spontaneous arrhythmias and potentially having the long QT. So if we had ways to block that overactive parasympathetic system, it may be beneficial. And so that's something we're interested in trying in the animal models. So that's the end of my presentation that I had, and I think that I'm on track to be at about 45 minutes, so we have plenty of time for questions. So I'd be willing to stop here and happy to take questions.
Great. Okay. Thanks, Dr. Nuel. That was amazing. That was quite a few topics to cover in such a broad, under one topic, autonomic dysfunction. Any one of these symptoms could be dedicated to a complete webcast in RettEd. So thank you for tackling all of them. We've had a couple of questions come in through the queue, and I was wondering if you can, I'm going to leave the screen with you so you can flip back to past slides if you need to refer back to them. But I'll just go in order that they've come in, if that's okay.
Okay.
All right. So the first question is around sweating. So mom says that she doesn't think her daughter sweats at all, which sounds like it's par for the course with Rett syndrome due to the autonomic system. So could you revisit what she should be worried about? Is there any testing that can be done to validate that? And what kinds of things can she do to help?
Yeah, that's a great question. I think that's very important thing regarding this abnormal sweating, because I think it is actually potentially something that can be immediately dangerous. And so, there are formal ways to do sweat testing. I don't think that that's really necessary. I think that we can appreciate, if you're in a hot place and you feel your child's head and they're not sweating and you are, then you're probably saying that, the child's not sweating appropriately. And I think that most of the ways to manage this is to be conscious of it, to try to avoid being in a hot situation. If you are in a hot situation, keeping track of your child to make sure they are not overheating, providing plenty of shade, seriously misting with cool water, and ultimately getting into a cool place. And I know that this can be an issue sometimes, and when I was in Texas especially, where it was very hot, and we used to write lots, and Judy Barish used to help write lots and lots of notes about the need for a air-conditioned school bus for transit to and from school, because the child with Rett syndrome really was not going to be able to tolerate being on a non-air conditioned school bus in 95-degree weather.
Thank you. Yeah, absolutely. It's a really good one to bring to the school team and get written into the IEP. And I know a lot of families really appreciate those new sports towels that you can buy at pretty much any sporting goods store that have some chemical treatment to cool. So the minute you add just water to them, the towel is cool, and they keep them around their neck and on their
Nice.
head. Yeah, are you familiar with those?
Yeah, but I haven't recommended it, but that's a great suggestion.
Yeah, when we did our getaway at Morgan's Wonderland down in San Antonio, I saw a lot of those towels being used. They did a good job cooling them down. Okay, another question related, I think, to that is the observation. So you talked about cold blue hands and feet. What about flushing for people who see their kids, their children's hands and feet get red and hot unexpectedly and kind of pass, or see flushing in their ears, different body parts? Have you experienced that clinically, and can you talk about that a little bit?
Yeah, no, that is definitely part of this whole process of the vasomotor. It's the opposite. And you could kind of think of it a little bit like the difference between hyperventilating and breath holding. So they're two sides of the same coin. You have and I usually like to say that all of these things, just like your child has trouble coordinating their movements to reach out with their hands or to walk, I would say the autonomic nervous system is also sort of looking like it's having trouble coordinating its efforts. And it sometimes is going wrong in one way and then wrong in the other way. So the flushing and the red, I've got the picture of that hand, is not as common as the blue, but it definitely does happen. And instead of having too little amount of blood flow to the periphery, to the skin, really, you're having kind of suddenly too much, and you're flushing. And so it's dilated. All the capillary beds are dilated as opposed to being constricted. So it's really, again, two sides of the same coin. It's not coordinated. I don't have any particular, great therapies, but obviously if it seems to be distressing, it's something you can also cool with the hot one. You could potentially cool by adding like misting or that towel you mentioned.
Okay, great. Follow-on question to that is there could there be long-term consequences of these disturbances over time? And are there clinical things that can be done to help? So, we often see our children in wheelchairs with their feet dangling. Can simple elevation throughout the day, the parent is asking for recommendations to the school and that they can do at home to potentially help. So it's vasomotor, brain related, but just positioning to get better circulation, can that help? And if there is no intervention that's working, can there be long-term consequences?
Yeah, they're good questions, very good questions. It's not, ultimately, yes, it does relate to circulation, but it's not circulation in the way most people think of it. People sometimes will have things that they may have diabetes, and the large vessels going to their fingers or their toes are getting clogged, and they're not getting the blood flow going out to them. The large vessels going to the hands and the feet are not having problems at all. This is all in what we call the capillary beds, the very smallest blood vessels way out in the end near the skin. And so the positioning aspect is not as critical as it might be if you had a larger vessel obstruction. And unfortunately, I don't have any great solutions about, recommendations of what to be done. I think, a lot of people, would put, more for the cold, put on more socks and something to warm their feet because it seems cold. Now, in terms of long-term consequences, again, I don't think there's any, but I don't know that for sure if there is any damaging long-term consequences.
Okay, thank you. I think, well, you've looked at a lot of children over a lot of years, and if you have not experienced long-term consequences, that is very hopeful information. Thank you. So I think a lot of clinicians mistake circulatory issues, related to their experience with diabetes.
Right.
And that's not what we're seeing in Rett syndrome. And I hope that's a relief to a lot of parents, because I know it can be very disconcerting. And, and you're wondering about the comfort of your child versus a clinical problem. And that's some good recommendations. Thank you.
You're welcome.
If we can, the next question that we have in the queue is trying to tease out some of the autonomic dysfunction related to GI system and vice versa in the interplay. So the parent is asking specifically or describing that a couple times a week, her daughter is passing air and having a lot of abdominal discomfort that seems to trigger tonic-clonic seizures, but also she seems to have episodes of hyperventilation, flushed face, sweaty hands and feet, dilated pupils, tremors, and shaking that kind of can last for a couple of hours. And she seems to, and then she passes gas, or burps, gets the air out of her system, and a lot of these symptoms seem to go away. So a lot of dysautonomic stuff going on, and then passing gas, and then she seems okay. Or the abdominal discomfort seems to increase, and then she goes into seizure activity. Can you talk about this continuum and what might be causing what? And of course, the recommendation of what to do about it.
Yeah, I mean, this is not an uncommon story. I do think there's a lot of relation between abdominal discomfort, probably oftentimes from marked constipation or a lot of air causing distension, and then seeing a lot of this autonomic dysfunction during the time of the abdominal discomfort. My general and with resolution with that abdominal discomfort. So I generally interpret this in a couple ways, that some of these autonomic abnormalities do seem to be triggered by pain or discomfort. And so they may be directly triggered because, the pain is making them anxious or irritable or, just hurting. And it starts ramping things up. And then before you know it, the children are hyperventilating or holding their breath. I also do wonder if there's a particular part of the brain where the sensory input from the autonomic systems kind of all come through one conduit. They're coming up a nerve called the vagus nerve, and they're entering into the brainstem in a particular region called the tractus solitarius. But they're kind of labeled lines. So you have, what I mean by that is you have sensory input from the gut going through this, but it has its own track, and then it's sending a reflex to the outflow saying, oh, your gut is distended, you really should start moving the gut so the response. And you have similar things like if your heart rate is too low and you're not getting enough blood, that is being fed through there, that then feeds out to cause your heart to beat faster. I wonder, this is now Jeff Nuel's supposition, not this is theory, not fact, or this is an idea, that there may be crosstalk. So some of the signals that might be coming from the gut that should be saying, let's have a gut response, may be crosstalking and causing abnormal responses in other domains, because they're not exactly carefully, it's not just one line. You're getting this crosstalk, and all of a sudden your breathing is starting to go wonky, and like you said, the pupils are starting to show abnormal response. So this is, again, just an idea I have, but the way the response is, I wonder about it. Now, in terms of approach to treatment, especially in the example you said, I mean, obviously, a lot of this seems to be triggered by this bloating, this gas. So, I mean, I think that again can be a challenging thing. Sometimes people have effects with simethicone or gas X drops, which help sort of break up the drops. It doesn't mean the air still has to come out, but instead of having just one big air bubble, it becomes a lot of smaller air bubbles, so it's not as pushed out, distending the gut. For people who have G tubes, that can oftentimes be helped by venting the G tube, which will be in the stomach before it comes out. I have not personally seen this happen much, or just because of the clinicians I've worked with, but I know that in other parts of the country, it's not uncommon at certain places to have basically a stoma, it's almost like a gastrostomy, a tube placed, but instead of into the stomach, it's placed at the beginning of the large colon. And that sometimes allows people to add fluids or other things to help constipation from the beginning of the colon to push it down. That also, I think, can be vented to allow some of the colon gas to be removed. Again, this is not something that I have been, that I'm familiar with clinically, because the people I work with just haven't done that. But I do know in other places that is not uncommon. Now, finally, there was a question of a relation with seizures. I'll say this, and I always counsel, especially if something that's related to autonomic dysfunction, that it's important to establish for sure that the events that you're describing truly are seizures. And I mean, that is not to say that they cannot be. That's that the pain or the abdominal discomfort could not be triggering a true seizure. But it's important to differentiate, mainly because of the approaches to therapy. And it's not uncommon for these things to trigger what I would call Rett spells, which may be tonic extensions for prolonged periods of time and maybe very much look like a seizure. But the issue is that the only way you're really going to know is to have a video EEG simultaneously to the time that one of these spells is occurring. And it will matter because the approach to, seizures is to give more seizure medicines, but that is not necessarily the approach to a Rett spell.
Great, thank you. I'm glad that you discussed that, because I think that cannot be reiterated enough to all of our families, that it really takes a attentive physician to differentiate between episodes and seizures, because clinical seizures lead to a lot of medications, and we don't want to be treating something that there's not a treatment for.
Well, and unfortunately, almost no one has become more awake from more seizure medicines.
Right. Mm-hmm. Okay. Thanks. And there was another question in the queue that asked about chronic constipation, and I think you touched on that a little bit. And we had Dr. Motil present another webcast about GI issues, and that recording is available to folks. And I think it's still this quest to understand the chicken and the egg, what is causing what, and what are some treatments.
Right. So I can say a little bit about it, but I would highly recommend everybody who's interested to go watch or listen to Dr. Motil's webinar, because everything I've learned about the gut, I learned from Dr. Motil. So I'm just going to give you a summary of things. Which is generally Miralax. But I would say, I know her bias would then, things like milk of magnesia, and then other things that she would say would be things that would help move, sort of get more of the movement. She gets a push from the things like Miralax, but you start milk of magnesia also mostly pulling water in. but also she might recommend other drugs eventually to start also get to stimulate the contraction sometimes of the gut. But I would definitely recommend Dr. Montiel's webinar as a great place to get the best information.
Yeah, thank you. Yeah, we've all learned a lot from her, as we're all learning a lot from you as well. Okay, I'm gonna let everyone know we've got 2 more questions in the queue. So we might be wrapping up our webcast early today. If you have any further questions, go ahead and take a minute to type them in now, and we'll be sure to get to them because we do have the time. And that speaks to how quickly you were able to present your information, Jeff. So we really appreciate that.
Well, you gave me a timeline, okay? I follow the rules here.
I know. This is fantastic. It's a tricky thing. Okay, so both of these questions come back to the breathing, or your first topic that we tackled, and a parent is asking about the startle effect that we see in a lot of kids when they wake up. And is that breathing? Is that seizure? Is it dysautonomic? What if you have any thoughts on that, and how to get them out of that period of seeing really frightened and tremoring and whatnot?
Yeah, it's a good question, and I don't have great answers for that, except for that is I've never seen that being a seizure, right? When the times that we have actually recorded that, it has never been a seizure. So it is sort of a startle arousal. It's not unlike what you might call a night terror, which is a parasomnia or an abnormal sleep that occurs in many people. I've seen it in my own children where they just have a sudden arousal and they're terrified looking and maybe breathing fast. So it could be that people with Rett syndrome are a little more susceptible to that. And then they also have this whole autonomic abnormality that is on top of it. There's probably a level of autonomic arousal in anybody who has a night terror, but because you don't have a coordination of the autonomic system, it might cycle more out of control in somebody with Rett syndrome. Now, in terms of what to do, I would say just to sort of, tell your child that it's okay, and they're probably basically slowly waking up. And as they wake up and get more cognizant of their surroundings, hopefully the event will start to subside. But I don't have any particular targeted, I would not start doing any drugs or anything like that for those events. You still there, Paige?
Sorry, I was on mute. Okay. Thanks for answering that. The next question is still related to the stereotypical breathing abnormalities. Those were some beautiful charts. Well, not beautiful, that's not the right description to call the charts, but enlightening and powerful to see that the breathing abnormalities are really pervasive across most genotypes and extensive across lifetime. And so the question is, again, this goes back to a previous webcast. Dr. Sockrider presented this last winter on respiratory illness in our children. And so the question today is, over long term, do you have any correlation between the stereotypical breathing abnormalities, gasping, breath holding, hyperventilating, and if they play a part in respiratory illness or respiratory health as a predictor to clinical management, right?
That's a very good question, and we've just been starting to dig into aspects of the natural history study that relate to things like hospitalizations and illnesses related to other clinical features like increased frequency of breathing abnormalities. So I don't know the answer to that yet, but hopefully this is something we will be able to present shortly, because the data is there. One thing I'd comment about, though, is that in a related disorder, in MECP2 duplication disorder, we don't see hyperventilation and breath holding, or if we do, it's very infrequent and not nearly the kind of severity of people with Rett syndrome. However, what we do see absolutely is a far, far, far higher rate of respiratory infections and hospitalizations for respiratory infections. Now, that does represent an underlying, probably, for a variety of reasons, susceptibility. But the point is that it's not just just having a hyperventilation is not something that obviously leads to having respiratory infections. There's a lot of reasons for the respiratory infections. Part of them are the risk of not chewing and swallowing well, and aspirating, especially in a situation that a lot of people with Rett syndrome have, which is another autonomic dysfunction that I didn't cover, which is excessive salivation. So too much production of saliva is also an autonomic abnormality, and having a lot of saliva with the inability to manage that saliva, not be able to swallow it as well, has the opportunity to bring that saliva bring it into the lungs instead of swallowing it into the stomach. And people's mouths have a lot of bacteria that, when in the lungs, can lead to pneumonias, aspiration pneumonias. So I would imagine that the oral motor dysfunction combined with the excessive salivation is more of a risk for respiratory infections than just having breathing, the hyperventilation and or breath holding.
Thank you. Thank you very much, and look forward to having some data to support these observations that I think that we all see. And I think the field of pulmonology would be really well informed to know where they can be more proactive in some areas. And I think you bring up a good point about being attentive to the type of breathing abnormality your child might have, and being especially attentive about that with secretions and during mealtime, especially with advising school programs and day programs, to maybe not eat just because it's time to eat, but if she's having a hyperventilation, just let her get regulated, and you might avoid some consequences. Would that be a good summary?
I think so.
Yeah. Okay, thanks. So since we asked for some more questions to come into the queue, we've got a couple. Parent is asking if there's a good resource to give to their treating physicians regarding these autonomic issues that you've described. It's been a real issue when her daughter has been admitted to ICU for other issues, and the ED gets distracted by the Rett syndrome autonomic issues and teasing those out from the real reason she's being admitted. I don't know what that is, but you have a reference or a resource to help?
Yeah, it's this is a great thing to bring up, and it's something that we are working to improve, and especially as we are moving forward with the natural history study and the renewal, to try to emphasize efforts to create more durable materials to communicate our knowledge, both based on the natural history study and also based on expert opinion on a variety of features. I think we need to do better at this to produce durable materials, meaning like a pamphlet, a downloadable item, some web page materials. I think we have relied a lot on a cohort of experts to help try to best communicate to other physicians or other medical care providers, but mostly related to providing that information in a direct, direct conversation. And I think probably as many people know, one of the leading people communicating that, Judy Barish, retired a little over a month ago. So that's one conduit of information that doesn't exist anymore. And that's also not necessarily, even though she did a great job, and people like Jane Lane, a variety of other people are doing great jobs communicating, it's not necessarily the most efficient. So I'd say that I don't have anything to point to. It's something I think we need to do better. It's something I'm sure we can work with RettSyndrome.org to sort of help develop those kind of guidelines or guidances, even if they're not guidelines, but just clinical experiences and things that can be related. And I understand the problem. I've experienced it secondhand many times. I, went through a long period where I was transferring patients from various places just to prevent them from having trachs put into because their child was breath holding, even though it was strictly a Rett breath holding event. So it's a problematic thing, and doctors try to do their best, but if they don't know about Rett, they may be scared by the clinical features that people with Rett syndrome present, especially in a scary new situation like an emergency room.
Yeah. Thank you, and I agree with you. And especially for the situation this parent presents, we're very much aware of this at RettSyndrome.org, and I think the handbook and different materials that we work with our team of experts to produce on a regular basis have done a great job describing it, but the natural history study data continues to yield, I think, much better insights, and we really look forward to working with you and the team to publish these kinds of brochures and handouts that are more discreet, so you don't have to be lugging that big handbook, which also doesn't always help with targeted information. And we're working to try to figure out a way to get these bite-sized pieces of very important information uploaded into electronic health record systems, both for the individual medical record, but also as resources system-wide through hospitals to help. Because you're right, with a number of families that we know living in the US right now with the disorder, it's not practical to always have them calling in to Vanderbilt or Baylor or any of our other centers of excellence for advice. I mean, it's just not always Monday to Friday, 9 to 5 that these issues come up. So I promise to our listeners, our attendees, and our entire community that we're constantly working to try to stay ahead of the curve with how doctors are now accessing information, digesting information, and getting practice guidelines for Rett syndrome. That landscape is changing. Good question. Okay. We have a couple more questions that have come in. And this one is about the heart issues and cardiac issues. Parent is asking if there's anything that they can do at home to monitor heart issues. Her daughter occasionally drops a beat, but the doctors haven't seen it clinically, so they won't look into it. And she doesn't want to miss it if it's something that's getting worse. So it sounds like a very able parent to be able to pick up on this at home, but it has not been observed clinically. What do you think?
So there are ways to do it at home. There's at home, it's called a Holter, Holter, Holter monitoring, where you essentially go in and they put a band on your heart. They set you up with ECGs, the little stickers, and you go home and you wear it overnight or a day or two, and you bring it back, and it's a little pack on it, and they can look at it. I have had people in the past who have done that, and some of them had periods where, their heart was suddenly slowing down dramatically or having, like you said, missed beats and stuff. So I think that is a realistic thing. Usually, yes, clinicians are going to be not super excited about doing it if there isn't a obvious clinical feature. Like, you know, and basically, probably the thing that they're looking for is that your child is having periods where they pass out or nearly pass out because your heart really slows, blood doesn't go to your brain, and you pass out, or you almost pass. You feel lightheaded and you almost pass out. So that's what they're kind of trying to. The doctors are looking for a clinical justification for it, but there is ways to do it.
Great, thank you. I think that's a great piece of information to convey, that the monitoring can be done at home. And if this parent would like to take that to their physician and request that and doesn't have success, feel free to contact me and we'll see what we can do. Because this is a symptom that, if identified, we can do something about, right?
Yeah, I think you'd definitely see a cardiologist and start working up a plan.
Yeah. Okay, we had one or two more questions come in about constipation, but I think I'm going to ask at this point in the webcast that, because it's not your area of specialty, that you go back and access the webcast delivered by Dr. Motiel. It's on our RettEd webpage on rettsyndrome.org. And if you still have questions after watching her webcast, again, feel free to get in contact with me, and we'll see if we can work out a plan that will help you troubleshoot this, because it's GI issues are big ones. Okay, last question in the queue, unless someone writes in another question, which we still have a few more minutes, please feel free to do so, is on saliva. So you brought up the topic of secretions. Do you have any experience with Botox helping with drying things up?
Yeah, Botox can be used to basically it's paralyzing the muscles that would be used to contract to get the saliva coming out to be expelled, and it definitely can do that. I generally, that would be further down the list for me. One of the things I'm always worried about with using Botox in the face is that people with Rett syndrome already have pretty disrupted oral motor function. And I worry if, you know, within not precise placement of the Botox, it might disrupt the innervation, the control of muscles of the mouth or the tongue, which might make the chewing and swallowing more difficult. My preference for saliva is using atropine eye drops, but not placed in the eye, placing one drop on a spoon and putting it and rubbing it on the tongue, and potentially repeating that later in the day. That's a little trick that we need to, again, probably publicize, again, learning it from Baylor, from Dan Glaze, that we found that does seem to have good success. It is daily, but it also diminishes the amount of overall body effects of that type of drug that you might see in a drug like Robenol, where you'd have Robenol can cause increased constipation and urinary retention, whereas just the atropine drop in the mouth has more limited whole body effects.
Thank you. I appreciate that insight. Okay, so Dr. Nuel, we are at the end of the text write-in questions. I know that as additional people go back and listen to the recording again, and those who are interested in the topic but were unable to join us today have a chance to catch up and watch the recording, we may have more questions come in. And if we do, again, you and I can discuss them, get some answers written up, and we'll get them posted to our website.
Okay.
All right. I think you're the work that you're doing is incredible. We're so supportive and happy for the center that you're building at Vanderbilt. We wish you the best success. Really good luck with the reapplication for the natural history study. I do want to put out a word of request and encouragement to everybody in our community to please continue to engage in research opportunities, from the natural history study to clinical trials to surveys, and every opportunity that you can find within yourself to engage in research, as you can tell from this presentation, is contributing to the field and really is creating progress in understanding the disorder, triggering ideas for further research in the basic sciences, in translational work, and into clinical work. And the natural history study really is that bridge of connecting research to trials to treatments, which is where we all hope that your work in particular at Vanderbilt will continue to go. So you're putting in the time to develop these studies. We appreciate it, and we commit to meeting you where you need us to be to enroll, and at rettsyndrome.org to continue to create awareness about the different studies so that families know how they can contribute. Okay, so I am going to, here we go. Okay, Dr. Nuel, we're going to let you get back to writing that application.
Thank you.
All right, thanks so much for your time. And to everybody on the call today, thank you for tuning in. I hope you had a chance to get some of the questions answered about your child, and that you learned some things, and that you'll share the link with others in your community who you know are struggling with some of these issues and would benefit from this particular webcast. We encourage you to visit our website, rettsyndrome.org/RettEd, and see the list of all of our upcoming topics. But in particular, on September 11th, we'll be discussing epilepsy and Rett syndrome, looking at everything from identifying trends and types of seizures and epilepsy in our children, to treatments, including looking at CBD and medical marijuana. Dr. Eric Marsh is an epileptologist, neurologist, and researcher at Children's Hospital Philadelphia, and it is really going to bring some great information to us in September. So we hope to see you then. In the meantime, please feel free to email me with comments and feedback so that we can fine-tune future offerings like our webcasts. We appreciate it. We appreciate you. We hope to see you here next month. And at this point in time, this will conclude today's webinar. Thank you, and we'll talk to you next month.